So last week we talked about cocaine-induced coronary vasospasm and how we use benzodiazepines to relieve that coronary vasospasm. And in this 12-week from last week, we saw that there were, prior to the benzodiazepine, quite a bit of ST segment elevations. And right after we gave the Versed, we noticed that there were these biphasic T waves in the inferior leads. And I wanted to talk just a little bit more about what these T waves are exactly, and I'm going to break this up into two parts. So to illustrate this point, EMS is bringing in a 54-year-old male, ongoing chest pain, and this is an obvious anterior septal MI with elevation in V2, V3, and V4. On arrival at the ED, the patient becomes pain-free and a repeat ECG is obtained. And we can see here that once again, we see these biphasic T wave patterns in V2, V3, and V4 once again. And so these biphasic T waves that we saw in the previous example with the coronary vasospasm and in this situation have a name, and they're known as Wellen's waves. And these are important to remember because what they indicate is spontaneous coronary reperfusion. So at one point, in this case, EMS had the patient, they had a completely occluded coronary artery, and then at some point during the transport or on arrival at the ED, when the patient became pain-free, there was a breakthrough of the clot, basically meaning that collateral blood flow was able to enter or go around part of the clot, and the distal portion of that heart muscle was now reperfused. And the way that I like to explain this is that imagine that we clamped one of the coronary arteries. When we clamp that coronary artery, we're going to see the obvious ST segment elevations. But the moment that we release that clamp, the first initial ECG finding that you're going to see are these biphasic Wellen's waves. And what they indicate is that spontaneous coronary reperfusion. In most of the literature, this is actually going to present as a proximal LAD occlusion, but they can also occur in situations like last week where there were coronary vasospasms. So we can see them in those two situations. Number one, indicating a proximal LAD occlusion immediately post-reperfusion, or in those coronary vasospasms as well. So important thing to remember for the pre-hospital providers is we are still activating the cath lab, and they are very high risk for reocclusion.